Hi everyone, I am Francesca Cerutti, gold member of Style Italiano Endodontics. Today, as a third webinar of this series developed in collaboration with Fanta Dental, we are going to take a step back and speak again about shaping, because in general shaping is the part that dentists are most interested in. Also because if you see a nice case, in general, the first question he asks the author of the case is which file did you use? And so we are talking about files more in detail this time. As usual, I recorded a short lecture in a video, so I will be available for any questions at the end of the recording. Enjoy! So the title of this lecture is Shaping with Style. And we are going to talk about some files that I pretty enjoy. But first of all, when we shape, we have to have clear in our mind which are the objectives of our shaping. And so we have to remember that the first thing that we want to obtain when we do shape the root canal system is to remove the soft and hard tissue that could give room to the bacteria. And so this is the first thing that we want that our files take care about for us. And secondly, we want to make room for irrigants, because we don't have to forget that we shape to clean, and so we have to give room for our irrigants to get to the apical third, which is the one in which we need them the most, and we have to allow them arriving there in a sufficient volume in order to be active against the bacteria. And then what do we have to do? We have to make it possible to obturate the root canal system. And nowadays we have very pretty systems that allow us managing even the most thin and the most conservative preparations. But if we cannot fit our obturation system into the preparation that we did, then it doesn't make any sense, because we need to obturate the root canal system for now to prevent the recontamination of the root canal system itself by the bacteria. And so this is another important step. And last but not least, we have to remember that nowadays we try to be more conservative in our shapings, because we want to preserve as much as possible the dentine, above all in the pericervical dentine area. That means from the bone level 4 millimeters up and 4 to 6 millimeters down. Why? Because this gives strength to our teeth. And so we can guarantee, or we can ensure our patient that the tooth will survive in the medium to long term, which is extremely important. So when we have an initial treatment, it's not so difficult to obtain a good shaping. Well, sometimes it is in complex anatomies, we have to negotiate with hand files, etc. But in most of the cases, we just have to follow the path of the pulp, and so we have just to try not to do procedural errors and to follow the original anatomy of the tooth. In this case, for example, I did a flap, I did a build-up because I could not isolate the tooth, and then I did the root canal therapy, and then I sent the patient back to the referral who did the crown. Okay, you see that 2 years later, the tooth is still in function, asymptomatic, and the lesion healed. And so this is a success, but it's easier in such a condition to obtain a good result, because the anatomy of the tooth has been preserved. The situation is completely different when we encounter retreatments or procedural errors, or some case in which the original anatomy of the tooth has been altered by pathology or by someone who did a therapy before we did. And so in these cases where there was a completely wrong access cavity approach, and so the colleague could not find the root canals, but luckily stopped before perforating. I have to manage this case in which you see the wrong access or wrong access and then nothing. Why? Because the patient was a bruxist, and so there was a calcification of the space of the pulp. And then after that, if you go more apical, you see that there still is a root canal, so I can't treat the tooth. What do I have to do? I just have to correct the access cavity. And notice that when there is a wrong access cavity in incisor, in general, its inclination is to buckle. And so one good thing that you could do when you have to treat incisors is to remember the inclination of the crown of the incisor and not to lose your reference point. You can do, as I did in this case, a multiple isolation. In this case, you will always have the nearby teeth in your sight, and so you will always be able to check if the inclination of your burr is correct or not. And in this case, you could also correct, for example, as I did, the inclination of the excess, and so put it in the correct direction for my files to enter. This was no easy case because it's very thin, calcified, etc. I had to drive with my hands the rotary files at a certain point just to arrive to the apex, because you know that the lateralis incisors has also a nice distopalatal curvature in the end of the root, so they can be difficult to treat, but eventually I made it. And the same thing can be said for the other side of the mouth of this poor patient that had the same problem, so wrong access cavity that was corrected, and then the therapy was finished, and you see the follow-up at the long term. And so in cases in which we have, for example, a treatment and a retreatment, what can we do? Well, more or less the same. We do the treatment first because it's symptomatic, the second premolar, and so I remove the pain from the patient because he arrived in an emergency appointment, and then I have to put a provisional restoration because I'm out of time. And in the second appointment, what do? I do as much as I can because it's more ergonomic for me, it's more ergonomic for the patient, and we have seen that the success rate of 1, 2, 3, 4, 5, 6 visits doesn't really change significantly. And so the more I can do in a single visit, the better in my practice. And so what do? I isolate, I do the direct restoration of the first lower premolar because it's decayed, I do the post-endo restoration of the second premolar, and I do the retreatment of the first molar because even in this case the existing therapy was not okay, and so I had to retreat. And you see that in the distal root there is a deep split that I was not able to shape with my files, but just cleaned and filled. And what else you see? That in the coronal part of this tooth there is a huge taper preparation because there was a post inside. So in this case there was nothing I can do to be conservative. I did what I could, but the coronal part of the tooth had been altered before. So in this case we just have to adapt to the situation. In this other case in which there is a retreatment, but you see that the existing treatment has not arrived even to the middle third. And so what do? Once I remove this paste from the root canal system, then I have to just shape, clean, and fill. And you see I'm much more conservative in this case. The healing arrives eventually, but the taper of my preparation is smaller, is more respectful of the original anatomy of the tooth. I remove only what I really need to remove in order to have my taper preparation, my room for the irrigants, and my room for the filling material. And so, when you need to treat the tooth, you need the tools. Apart from the knowledge, then you need the tools to do. And Fanta has developed a system of files which is called 𝗦𝗵𝗴. These files have a very particular cross-section design with two active cutting points. It's like an S, the shape of the wire. And another important thing about this file is that it has a flat section. Why is this so important? Why the flat side design can be interesting in a file? Well, first of all, because we have to understand that with this kind of design, then we have more room for irrigants because the volume of the file is smaller. And also, we increase the possibility to remove the debris during the instrumentation because there is more room to make the debris come out coronally, because these files have to be used in a continuous rotation. And so the file rotates and the debris come up, 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 up. And then we also have less debris accumulation on the spires. The file is thinner, so it becomes more flexible. But this cut is not very deep, so it is flexible, but the fact of having this flat side design does not increase the risk of fracture for the file. And then they have this surface heat treatment that makes them a control memory file. They are more sensitive at room temperature, so I can pre-bend them, and they can be pretty interesting. When we go more apical in this file, we see that the tip is non-cutting. And so what does this mean? It means that there will be a less screw-in effect of the file inside of the root canal, and also that I decrease the risk of make wrong paths, perforation, iatrogenic complications in general. What about the wire? The wire is very resistant to the cyclic fatigue thanks to the surface heat treatment that goes through. And it is also extremely flexible with a good memory shape and a nice cutting efficiency. So it can be a good choice for most of the root canal therapies. Starting from these points, Italiano Endodontics developed a sequence of files taken from the 𝗦𝗵𝗴 family, and we introduced these 4 instruments. One is completely innovative, which is the first file of the sequence. It is a 13 in tape 03 in taper, and then we have a 2004, 2506, 3504. The benefits of using this sequence, apart from the fact that we have seen before, so double S cross section, the flat design of the file and the non-cutting tip, is that they are very resistant to cyclic fatigue. They can be easily used by almost everyone. They are safe and they have a nice cutting efficiency while maintaining a nice debris removal. So let's look closer at the sequence. First of all, we have in our package a number 10K file, taper 02, tip 010, the regular one, done in stainless steel. This helps us in our glide path, working length measurement, etc. Then we have the 1303. The 1303 is made in AFL wire and is the first file of this sequence. It's the file that we are going to use to make our glide path and to arrive to the apex. And then we have a 2004. So we increase a little bit the taper, but it's extremely conservative. The tip is 20, and so we can use it in very complex anatomy. 06, which is still extremely flexible as a file. It can be the finishing file of our system in many times, and it is made in AFR wire, so it's a little bit more flexible than AFL, but still has a good cutting efficiency. And then, what if we need even larger files in a tip? We have a 35, but in this case the taper is reduced because I don't need a 3506 file. In most of the cases, the 3504 is more than enough. So I save coronal structure while going to enlarge the apex to the size that I need. How do we use this sequence? The rotation per minute, so the speed, is between 4 and 500, and the torque is 2.5 Newton. In this case, we can use the file effectively, but also safely. And how do we use them? We can use them with our 𝗦𝗫𝗄 motor. So let me remind you a little bit the characteristic of the 𝗦𝗫𝗄 motor. It is a wireless motor that can be used in 6 different positions, so we can change the position of the head of the endomotor in 6 different places. This is extremely ergonomic and allows us to see the screen of the endomotor in every position that we need. And then what can we do? We can preset. We have 10 different memory settings that allow us to work with different sets of files without having to set everything every time. So we can have our programs and we can switch from continuous rotation in a clockwise motion to the counterclockwise, and we can also have reciprocation, and we can set the angles of the reciprocation movement that we want. And always we are going to have the torque control. So we will be able to see in every moment which is the stress that our files are encountering inside of the root canal system. And then we can also set the auto reverse, auto stop, so we have some system that help us in being good in our shaping. And this is the endomotor. But one of the worst nightmares of endodontists is to break a file. And this is what my colleague 𝗦𝗫𝗆𝗵 and I discovered in our podcast. We made a poll among the dentists, and we discovered that the vast majority of dentists has as a worst nightmare breaking a file inside of the root canal. That is nice as a nightmare, and of course it can be very difficult to face. And so we have to try to avoid this kind of problem. And the first thing that we have to do to avoid breakage of files is to make a correct access cavity, because this is going to remove most of our problems that we encounter in the coronal third of the tooth. And then we have to negotiate the orifice a little bit, do some coronal preferring. If we see that the file cannot proceed freely inside of the root canal, we have to prefer a little bit. And then we do the scouting, so we know what you're going to encounter, how the anatomy is going to be, and then we have to ensure the patency of the root canal that we are going to treat. And then, last but not least, and this is an advice that I will always give to the dentist, is try to use the nickel titanium files just one time, because we have to be extremely sincere. There are situations in which we use a file for a single time, we wash the file, we see that the file is deformed, we see that it's not perfect, we better discard it. Otherwise, we take the risk that the file is going to break. And so this is something that I want to happen. I prefer to lose money, discard a file before, than have to retrieve a broken instrument later, because it's more time consuming, it's more difficult. I'm not sure that I'm gonna do it. I'm not sure that I'm gonna bypass it, because it's not that we are able to treat every separated instrument in the heart. And so it's better to prevent. But now that we have the objectives clear, we have decided which tools we're gonna have, we need a protocol. We need to know how to use these tools in a predictable way. And you know that at Italiano Endodontics, we want to make things feasible, teachable, and repeatable. And there's a reason why, because we want the most of the people to be able to succeed in what they do in endodontics by following our protocols. And so, let's differentiate, because not all teeth are the same. In a wide and easy canal, which is straight, wide, I have no difficulties given by the anatomy, I will use one protocol, which is different from the protocol that I'm going to use in a regular canal. That means that it's maybe slightly curved, but a little bit smaller than the one that we saw before. So maybe I could encounter some difficulty here. Okay, I'm going to have a different behavior, and I'm going to have another kind of behavior in canals that are narrow, difficult, aberrant anatomies, etc. Because in this case, I will have to pay even more attention to what I'm doing. And so, let's see them one by one. The first, independently from the anatomy of the tooth, you have to do your scouting. That can be manual or mechanical. Just try to see how the root canals are. And then decide. If your canal is wide and easy, you can just go straight to the working length with your manual cave file, with your 1303, with your 2004, with your 2506, with your 3504. And so sometimes you probably are going to need even larger files to manage the apex of these teeth. But in general, this is a case in which you have no problem in arriving to the working length with your files. In this case that I'm showing you, it's a little bit more complex because it's a retreatment. And so what do I find? I find a thermophil that is stuck at the apex, so I have to remove it. I remove it with a loop technique because it's very, very engaged, and I'm finding a difficulty even with the loop to make this plastic come outside from the root canal. But when I make it, I found a straight canal, pretty broad, and so what do? I take directly my 1303 and I bring it to the working length. Then I irrigate, because we have to remember that we want to remove the debris, and I am at the working length with my manual file. So what do? I take all my sequence and I bring it to that working length. I'm not even making any effort because the canal is large. And so 1303 you've seen, now you're seeing 2004. The file comes out clean. So I need more, 2506. I use it in packing motion, and then I use my 3504, and then the 3504 has worked a bit. So this is my final diameter of the apex. I do all my irrigation procedure that we are going to see in the next webinar. I activate the irrigant, and then I just do my apical gauging. That was even more, and I choose the correct gap aperture point for this tooth. And then I go and do my filling procedure. So this is the sequence that we are going to use in wide and straight canals. All the instrument of the sequence taken straight to the working length. And we will see there is no problem. Also in this canine, for example, I use the same approach. And the only difficulty is the canine is longer, so maybe you need longer instruments. But otherwise, there is no difficulty. In normal cases, in regular cases, so those canals that are straight or slightly curved, I can do one thing. I can just skip one file in the sequence. Because when I see that my 1303 goes, I just use some coronal pre-flaring because maybe before the curve I want to play it safe, so I drive my 10K file, my 1303 short to the working length, and then I skip directly to the 2506 and I see if it's working or not, because the room that I have allows me just to skip a file in the sequence. And then what do? I take my manual file again and I go searching for the working length. Once I find my working length with the number 10K file, then I can bring my 1303 to the working length in packing motion. You see, I go up and down. I'm not brushing. Why I'm not brushing? Because I don't need to brush, because I don't want to remove dentine in the pericervical area. And then I use my 2506. You see that the 2506 here goes smoothly to the apex. If I had encountered some difficulty, I would have not forced the 2506. I would have taken my 2004, taken it to the working length, and then I would have taken my 2506. So it's up to you guys to decide what you are going to do. In this case, the apex was larger. I took the 35. It's the tooth that decides which is the last file that you're going to use, unfortunately, because you have to adapt to the anatomy. So you have to be flexible in your mind and just understand which is the size that you have to use in your files. And then I do the filling. And this was the regular. That was a monoradicular tooth. Here we have the same situation in a molar, in a lower 7, that I had to treat because the patient was in pain. So I open my excess cavity, remove all of the existing restoration, go with my pre-flaring first, then to the working length with manual files, and then to the working length with all of my sequence. And you see, it's a regular molar from the lateral canal. Also in the middle third, that if you look close, you see there is a lateral canal that is departing from the distal root. And you see the follow-up at 2 years. Everything is working nicely. The patient has also had a surgery to remove the residual cyst that there was in the site of the first lower molar, and you see that it is healing over time, so I'm not cheating, and this is the result. Another case of a regular tooth. There is a confluence of the root canals in this case. So what you're going to do, how are you going to modify your sequence? You're just remembering to drive to the working length only one file. You choose the root canal in which it's easier for you to reach the working length, and that is the canal that you're going to shape up to the working length. And the other one, the confluent, you're going to shape it just up to the confluence. In this case, you reduce the risk of breaking files, you reduce operative times, and you reduce the loss of dentine for the patient. So it's a win-win situation. And I do the post-endodontic restoration, I do also the restoration of the first molar, and it's easy. Another case, anatomy that starts being a little more complex because we have a second lower molar with these confluent canals, etc. The rule is always the same. So you just have to remember to try to be as conservative as possible and to just follow the sequence that I told you before. 13, if you can go with the 25 directly, go with the 2506, or if you can't, 13, 20, 25, and that's it. What about cases that are difficult because maybe they are calcified, the canals are narrow, etc.? Well, in this case, you have to be more careful and you have to do a little more job because you have to pre-flare coronally with all the sequence up to 2506. In this case, what's happening? It's happening that you remove all the pulp chamber roof, and then you start see the openings of the root canals. You can use an orifice opener. I prefer to use ultrasonic tips just to work at the level of the orifice to remove the coronal interferences, and then with your files you just go in the coronal 2/3 and you just pre-flare them a little bit. What are we doing in this case? We are removing all the dentine that is going to create an interference coronally for our files, and so that is going to make it harder for our files to proceed inside of the root canal. We remove the interferences, our files are working better, we don't have the transportation of the root canal, and we decrease the risk of fracture. So it's just a step that takes you a few minutes to be completed, but it's completely worth it because you work better and you work safer. And so you use your sequence short to the working length, and you see I'm going also directly into the MB2 canal because I'm quite confident that the cutting efficiency of the file will be enough for me to negotiate also the MB2. And then once I am able to arrive to the working length with my manual file, then I do my glide path with a 1303. And so I arrive there, I just shape a little bit the root canals, and then I'm going to just shape them up to the final size. And so I go with my 2004. If it's enough, I stop there. If it's not enough, I take my 2506, and then I do it. It's not enough, 3504. But in very complex cases, in general, you just stop to the 20 or the 25. This is another situation, double curvature in the major roots. The tooth is not easy because it's a second lower molar, so also the access is not easy. But then I follow the same protocol and I achieve the same result. So there is a repeatability of what you do. Same here. I like second lower molars, evidently. In this case, the problem was due to the impacted tooth that had helped the development of a very large decay on the lower 7. And so what do? I remove all the existing coronal restoration, remove the decay, do the treatment, but in this case I do not restore immediately because I can't. So once the patient extracts the lower wisdom tooth, then I do the restoration. And you see the 1-2 years follow-up of this case. Premolars. You know I love premolars. This is not a simple premolar because there is a moment in which the root canal disappears, and so I think that there's gonna be something like a split. Yes, there is a split. So how do I treat it? I have no problems in the middle third and in the coronal third because it's a big straight canal. But then I have to be extremely careful in the split. So the fact of having a file that I can slightly pre-bend and it's going to stay like that helps me a lot. And I do all the steps in the same way. So remove the decay, negotiate the orifices, do the coronal pre-flaring with all the sequence up to 2506, and then manual file pre-bend, I arrive to the working length. Once I did it, I pre-bend 1303 and I go. And I finish to 2004 because there is no reason to enlarge more. I am able to clean, I'm able to feel good. And then I also do the direct pulp capping on the second premolar. Immediately I do the build up because I want to make an overlay on this tooth. And this is it. Immediately after, at 1 year follow-up. Still working, both the direct pulp capping and the root canal therapy. And so we see one last case. In this case, it's these periodontally compromised teeth that are sent to me by my periodontologist. What do? I do the same. So first of all, remove completely the coronal restoration and then remove completely the decay. In this case, you will be able to evaluate which kind of post-endodontic restoration fits the most this situation. And then you go. I do my pre-flaring. How? 1303. And you see, I do it in every root canal. And then the same sequence. This is almost real-time video of what I'm doing because I wanted, it's an older case than the Arrow Pro, so I'm not using it for that reason. And you see that I stay short from the working length with my 1303 and then I take the 2004. And with 2004 I do the same. I just do some packing motion and I let the file arrive until it wants with no effort. In general, it's 2/3 of the working length. You take your approximate working length, you remove 5-6 millimeters. This is your provisional working length. And then what do? I clean because I don't want the breed to stuck inside of the root canals and to create blocks that I'm going to struggle to pass later. And you see that when I can go deeper, with my shaping, then it's easier. And so what do? I proceed with my 2004. 𝗕𝗶𝗁𝗵, 𝗕𝗫lingual, distal. And what's another thing that I try to spot as soon as possible? The presence of confluences, for the reason that I was telling you before. So if I understand that there is a confluence both in the mesials and both in the distals, then I know which canal I have to shape up to the working length and which canal I have to shape up to the confluence. So I want to make my life easier. I just check the fit of my 𝗕𝗶𝗫𝗵 points. I do my final irrigation protocol. I'm going quick. I activate. I use a hydraulic sealer. I just pack my 𝗕𝗶𝗫𝗵 points. And I do immediately the post-endo build-up. Why? Because I want to make an overlay in this tooth. So I'm going to take immediately the scan for my laboratory to produce the composite onlay or overlay. Because I want to save time, I don't want to put a provisional restoration because there's a bigger risk of coronal leakage then. So I do immediately the composite. And then I do my preparation. And so you see that it's a 2 hours workflow, 1 hour and a half, it depends on how fast you are. It's worth it. Okay? So I hope you enjoyed the lecture, and if you have any question, I'm here to answer. So it looks like there's no question, and thank you all guys for watching the webinar. And if you have some more questions, just write them and I'll answer back. Bye.